some brain stuff. We're going to, let's see, we're going to talk about motorcycle helmets, obviously, here. We'll have a good time, and get you guys out of here on time, too. In case I forget to tell you, there is a quiz on HealthStream, as usual. Same questions for everybody, pretty straightforward stuff. All right, so we'll start off talking about some drugs. This is my first attempt at doing CE on the iPad, so I think it's going okay so far, but we'll see how we do. So some stats to go over first to put in perspective. We talked about drugs a little bit in the last CE and overdoses and drugs of abuse because we're seeing some wacky stuff out there as far as illicit drugs. But I think we see in our current clinical practice, but maybe underestimated how often we have prescribed drugs causing overdose death. So drug overdoses have passed car accidents as the leading cause of accidental death in the United States. Pretty impressive, huh? So if you don't do drugs, you've wiped off #1 on your list, all right? 1980, 6,000 overdose deaths. 2008, 36,500 overdose deaths. So a 6-fold increase in death, accidental death from overdose. So you think, well, that's got to be all cocaine and heroin and all that illicit stuff. Not so. 40% of deaths are due to prescription pain medication overdose. So of that 36,500 deaths in 2008, probably 15,000 of them were from Vicodin, Lortab, Norco, OxyContin, etc. type overdoses. Something I think we've noticed, we've seen every day. Is it fair to say, I see a couple guys that maybe are a year or two past being a rookie in this room, fair to say that in your practice lives you've seen an increase in prescription drug use? I'm asking for feedback here because I've been, I've only been out of residency for 7 years. Prescription drug overdose and prescription drug abuse increasing problem? I think so. That's what I'm seeing in the ER.
Wouldn't you think that the antidepressants were attributed that too? Because that's a lot of mind altering and kind of relaxing. Yeah,
fortunately, the antidepressants what we'll call the SSRI class, like Prozac, Zoloft, the most common ones, it's really hard to kill yourself with those, fortunately. You can eat a whole bottle, a 3-month supply of Zoloft. Don't try this at home. And it's probably not going to take you out. Whereas if you eat your 3-month supply of OxyContin, probably going to take you out. Yeah, so now some of the becoming more common antipsychotics, those will take you out if you eat a whole bottle of those things. And certainly benzos, prescription benzos.
Which classification is a lot of kind of recreational deals for a lot of young people is to take like a Xanax and drink with it. Yep. And it's like a lot more.
Xanax is a big problem. Yeah. Yeah, we, not just a couple days ago, and I was working in the ER, and so Care Flight landed with 2. One was a CPR in progress that turned into a CPR in flight from a wreck. That was the passenger. The driver, when we searched, when we were taking off her clothes, a bunch of Xanax bars fell out of her pocket. I think that is just an incredibly common problem. In the last 10 years, there's a 4-fold increase in the volume of prescriptions for pain medication. This is an editorial comment from me. When did we start measuring the pain scale?
10 years ago?
About 10 years ago, right? So we all come to work. I do the same thing when I come to work in the ER. I kind of want to know what the rules are. And the rules, as laid down by all hospitals, one of the things hospitals are graded on, and thus physicians, are you treating people's pain? Joint Commission and developed the smiley face pain scale, smiley to sad face pain scale about 10 years ago. And that became part of the job to get people's subjective, objective pain score down. Now, I've never been in the ER with a kidney stone or a broken bone, so I've probably never had true pain. So one of y'all can come kick me in the rear end afterwards and I'll give you a pain score. But what I'm saying is there's an unintended consequence to everything. And I think that maybe some of the unintended consequence of very actively measuring pain scales is a increase in prescription pain medication. And now we're seeing some of the unintended consequences of that. So we're going to talk about enforcement of these laws, both federal and local enforcement of these laws. So what's a controlled substance? It is a drug or chemical is manufactured, possession, use, regulated by the government, and the DEA is responsible for suppressing illegal drug use and distribution by enforcing the Controlled Substance Act. The Controlled Substance Act was written in 1970. It will be enforced in 2012. So 42 years later is when it's going to really start being enforced. We as a fire department, and I'm speaking for really all local fire departments and all local EMS systems, became aware. I'm going to give you a ballpark of about 6 to 9 months ago. The DEA called a meeting in Cedar Hill, and we sent a representative, as did most fire departments, where they said, we're going to start applying the Controlled Substance Act from 1970. And we have to apply it to fire departments. But the problem was, this was not written for fire departments. This was written for hospitals. Think about how EMS was practiced in 1970. Did the Plano Fire Department have ambulances in 1970? Nope. Did we have paramedics in 1970? Nope. If you had a bad wreck in Plano, who went?
Your home. Harrington.
Exactly.
Harrington Funeral Home.
Exactly. So were they carrying morphine and Versed and King Airways and endotracheal tubes and shocking people at 360? No, man. They were just scooping them, right? So we weren't taking the medicine to the scene then. We're taking all the stuff to the scene now, better than we do it in the hospital in a lot of instances. So we've way evolved, but we're going to apply a law from 1970 in 2012. And I'm going to present to you how that's going to create some issues. And even the DEA agents will admit, after they get done giving their official presentation, and say, go talk to your congressman. We've got to get this law changed, because this law was written for a hospital that has a static pharmacy and can walk drugs down the hall or tube them to another part of the hospital. We can't walk drugs from logistics to 13s. We can't tube them over to 1s. Our drugs sleep in 13 different locations, and that presents an issue for the way the DEA has modeled the Controlled Substance Act. All right, so let's talk about what are some controlled substances and the certain schedules. So Schedule 1 is highly addictive, no medical use. Remember I said no medical use, because you'll see on the next slide there's medical use. So no medical use, Schedule 1. Medical use with extreme restrictions, Schedule 2. And it kind of sifts to a little bit less concern in each. So Schedule 1 is the most addictive, and we're never going to carry anything Schedule 1, I wouldn't think. Schedule 5 is the least addictive, but there still is a mild potential for abuse. These are drugs that are on Schedule 1. GHBs, gamma hydroxybutyrate, cannabis, which is marijuana. Remember I said no medical use, except if you live in California, Colorado, Oregon, or other states where you can prescribe medical marijuana. And from what I understand from my brother, who understands from friends that live in California, my brother lives in California, all you have to do is say the right words to the doc out there, and it's pretty easy. I understand that I got some glaucoma today. I've lost my appetite.
Can't sleep.
I can't sleep. And you go to the Starbucks of marijuana and get it filled. I don't think in the political environment in Texas this is ever really going to pass here, but there are 200 medicinal marijuana shops in the greater Denver area, to give you kind of a picture of, once you legalize this, how it goes. Heroin, peyote, PCP, China White is super pure form of heroin. So these are Schedule 1 illegal drugs. I believe cocaine is on that list too. I actually did use cocaine for medicinal purposes when I was a resident on people with severe nosebleeds. It led to high patient satisfaction as well. And no, it is a major vasoconstrictor, and so it will stop a nosebleed. All right, we have gone on to other things, so I've never actually applied nasal cocaine in Plano, Texas, but back in Temple in the day, we did that a little bit. Schedule 2. So these are drugs we're more familiar with. These are drugs that are heavily regulated by the DEA, but can be can certainly be used in a medical environment, and we use every day. Morphine is obviously one of our most used medications, and it's a Schedule II. Fentanyl, Percocet. So Percocet is a oral narcotic. It's a oral morphine derivative. You see Ritalin, which is a very commonly prescribed ADHD medication. Very effective when used appropriately. But it is a form of amphetamine and has a high street value as well, and therefore is highly regulated. Methadone helps people get, it's a long-acting opioid agonist-antagonist on the mu pain receptors, and so it is something that helps people get off heroin. So you see sometimes people on methadone when they're in rehab. Demerol, which is on the outs with most ER docs because it has more addictive properties than most opioids. So we really try not, and you'll hear a lot of people will say, I'm here because I have such and such, and I would specifically like Demerol and Phenergan. And we specifically don't stock it in our drug box in the ED because of that. Dilaudid, which is, as we've talked about before, a very strong form of morphine, roughly 6, 8, 10 times as strong as morphine. Schedule III is anabolic steroids. So if you visited the Rangers dugout in 1999, you probably would have, if you were a DEA agent, you probably would have had to look the other way. Codeine, some preparations like hydrocodone, Vicodin, Lortab, etc. And then ketamine, ketamine is a very commonly used sedative, anesthetic, hypnotic for pediatric sedation in the emergency department. We use it every day because we'll give a child an intramuscular shot of ketamine, 4 milligrams per kilogram roughly, and they zone out for about 30 minutes. It's the only sedative that also has some anesthetic property. And so it's great because you kind of get a 2-for-1, and then you do some local anesthesia and you sew up that big lac up here. Or you give them some ketamine and then you reduce their elbow or pop their wrist back in. It is one of the most common sedative anesthetics in the planet. It's used in veterinary medicine. It is used if you fall down a mountain in Burma. If you rupture your appendix in Thailand, you're probably going to get ketamine as your anesthetic. But it's called Special K on the streets, and it is abused. Schedule IVs. Pretty common stuff. This is the benzos, and then Ambien, which is a similar to benzo but not quite a benzo medication. These are the agencies that help regulate controlled substances: Department of State Health Services, the U.S. Drug Enforcement Administration, and then the DPS. And then, so if there's an issue, the DPS sends out the Texas Rangers, and I'm not talking about Julio Franco, to visit you.
Hey, Doc.
Yep.
Is there any kind of method or reason to what drugs have the name written on them, on the pills, individually, and what ones don't, and why they don't? Because, I mean, we go to a lot of old people.
Yeah.
We don't know what drugs are on their family, don't know what drugs. They just got the box with the days of the week. And
yes, it is a problem. There are some great, if you're iPhone or Android type person, there is no method to the madness of what drugs. The only thing that I think is required of each drug is that they have some kind of unique identifier, numbers and letters on there. And so there's a number of apps or tiles that you can get that are, if you punch in the number, it'll pop up some color options to tell you what it is. But there's no method to the madness of why.
I saw that slide on the Percocet, and it looked like there were 20 different types of pills.
Yes. There's 40 different looking Vicodin Lortabs. It's frustrating. So you're right. When you get the geriatric Monday through Sunday box, it's hard, unless you got a while to sit there and do your pill recognition app. It's hard. So here's the regulators. And here is, I specifically have talked a number of times with Lisa Sullivan out of the Dallas office of the DEA. She's very easy to talk to. She's relatively new at this, and she's really the first person that is sort of a public face of the DEA. Before it was just you said the DEA and everybody wanted to go like this. There's actually somebody to talk to now that returns your calls, and you can ask questions to. She emails me back if I email her on Friday night. So at least we're getting some answers as to what we're supposed to do, because the expectations of us and all EMS systems are going to be increasing about how we how we control and monitor our controlled substances. So again, who regulates this? Who watches us? The DPS issues Texas controlled substance licenses, and the Department of State Health Services in their Texas Administrative Code for EMS, where they talk about a lot of different things we're supposed to do, there's no mention whatsoever of anything related to controlled substances. So again, that's the man that will come visit you if you do wrong. And all of the real laws are found in the Code of Federal Regulations. So that's this big red book right here. And so first question I'm going to throw at you. In federal or Texas law, are we required to double lock our controlled substances? No. Actually not. It's more of a myth. I thought that was true also. Your schedules 2 through 5. So even if you were to carry some, some hydrocodone or codeine or anything out there, that's got to be locked up, but it's just got to be, shall be stored in a securely locked, substantially constructed cabinet. It doesn't have to be double locked necessarily. Are employees required to notify management if they notice discrepancies or diversion of controlled substances? So what they're saying there, this is in DEA speak, it's basically the same thing as like a child abuse type law. If you suspect child abuse, you are required to report it. If you suspect narcotic diversion, you are required to report it. This is not a threat. I'm not standing up here going, oh my gosh, I'm threatening you guys. I'm just trying to tell you what the laws are out there. So that if there is, if I suspected another ER doc was taking fentanyl home and I kind of knew about it and they could link me to knowing about it and not having reported it, it means I'm going down too. That's the example I'm trying to give you. Record storage. How many years are we required to keep records of our controlled substances? 2 years. Records must be kept at the registered location and available for inspection. So that's where things get a bit interesting with registered locations. Keep that in mind. Okay, here are some forms that I have to be familiar with in regard to just when you think, I'm just going to give 4 of morphine for this broken ankle. There is a lot of work to get to that. I'm giving 4 of morphine. And I know y'all have a lot of work with it too as far as documentation goes. But there's a lot of work that goes in just to getting that on the apparatus. So let's talk about the forms so you have some perspective. This is a DEA 222 form. So a 222 form has to move around with any Schedule II medication. It's a triplicate form. There is no electronic ordering of Schedule II controlled substances. So when we order from Boundtree, we send them a 222 form with everything we need. When the drugs come back from Boundtree, it comes with it a 222 form. And then I have to have a power of attorney to list who can receive it. Otherwise, they're going to require me to be there for every receipt of controlled substances. So we've got a power of attorney for the EMS captain, EMS battalion chief to receive this. And then if we have to destroy any controlled substances that are expired, we have to have a reverse 222 form that goes out. So we'll talk more about that. Took some pictures from my buddy Tim Hartman for a presentation he did. He's the medical director for McKinney. This is his the DEA controlled substance certificate. So you have to have 1 for each station. So I have 13 DEA licenses for the Plano Fire Department and then a separate one for my private practice. That way if I'm dealing Vicodin on the internet, it won't take the Plano Fire Department down with it because that's done on my private practice one. Don't worry, I'm not doing that. Same thing, if somebody starts dealing morphine on the internet, then I can still go practice as an ER because I have a separate DEA license for that. So not only do I have 13 DEA licenses, 1 for each station, I have 13 DPS licenses, 1 for each station also. So federal and state. All right, this is the Texas Medical Board Physician Permit. Just wanted to give you an example of what that is. And in the future, that will probably have to be posted at each station. Much like a restaurant says we can serve food, we will have that out saying we can serve morphine. May I waste my expired controlled substances down the sink in the presence of a Texas police officer? So obviously, if it's not expired, you can waste it, right? You can waste it in the presence of another provider and document that. What I'm getting here at is the expired thing. if we got a lot of morphine that at a particular station that expires, can we just waste that? It's kind of a loaded question. I'm asking that for a reason. No, you can't. So if you want to waste, you got two options if you want to get rid of controlled substances that are expired. If you want to destroy them yourself, you make a date with the local police department and a DEA agent. You go to incinerator and you have to incinerate them. That's the only acceptable form of destruction to the DEA is incineration. So we'd have to go up to the incinerator in McKinney and meet the DEA and take the Plano police with us, I believe, to incinerate any controlled substances that are expired. Or you can send them to a reverse distributor. A reverse distributor, then you pay them to take your expired controlled substances back, and then they'll get rid of them. And that's an example of reverse distribution where McKinney is sending fentanyl and morphine to Stericycle to destroy their controlled substances. I'm trying to give you a picture of how much work there goes with just navigating the waters to deliver controlled substances to patients. So here's some of the rules. Here's the new rules, or the 40-year-old rules that are going to be applied in 2012. And that is, we have two options of how to set ourselves up going forward. We either have to go to a pharmacy and get the controlled substances, and they would act as our distributor, or we have to set up our own distributorship within the Plano Fire Department. So we looked at this model, and this is called the mid-level practitioner setup, and that would be, for example, you would drive through on Med 10, the CVS, into the pull-through there, and I need 14 of morphine, please. Tube it over to you. I mean, I'm being a little sarcastic, but that's really not too far from how it would be. You would set up with the local pharmacy, and we would get our controlled substances through them. We considered that. It is nice to turf some of the responsibility to them, but two issues that I see with that. One is that one of our neighboring fire-based EMS systems tried that. Didn't work real well because it works until they actually don't have what you need, and that they ran into that situation. And so they decided to take it in-house. The other issue we personally ran into is that we had a local pharmacy, had an agreement with them to stock antiretrovirals in case we had any exposures. And that was a good idea until we needed the antiretrovirals and they didn't have them. And so you have to decide if you can trust an outside entity to always have this in our operational model, which is 24/7, 365 on holidays. So we are more likely to go this route, the distributorship setup. And that would be that, say, Boundtree as a pharmacy, Logistics as a drug distributor, and then each station as what would set up in the DEA as a mid-level practitioner. So the fire department would have its own DEA and DPS license for logistics, and then I would continue with the 13 DEA and DPS licenses for the 13 stations. So drugs would arrive and be received at logistics, and then they would be fanned out to the stations. Now, one of the things that would change is that we've got to have a safe at the stations with med units for controlled substances. Otherwise, we're going to be driving back every day and restocking morphine. So what you'll see is you will see probably in the near future a safe for narcotics, for controlled substances at a med unit house. Over the last couple of months, once we found this law was going to be applied and that we were required to take one of these two routes and how we were going to set ourselves up, we've done a lot of reaching out and calling around to try and find out what other EMS systems are doing locally. What's the sort of the local standard? McKinney and Allen have already set up their distributorship, so we've been talking to them a lot about how they've done this. And it was Carrollton who tried the pharmacy model and had some challenges with that. So there's going to be some new processes coming down the road. First is that you'll see safes in the near future at med unit houses. Second is that we found out that we're probably the only system that doesn't do a face-to-face checkout of controlled substances on the med unit. So we're going to go with we've developed a form, and we're going to go with a face-to-face checkout of controlled substances on the med unit at 6:30 every day. So I'll try and give you a realistic picture of how much time this is going to cost you in your daily life. And so if you're an FRS paramedic on a med unit, coming on or off going, it's probably going to cost you an extra 15 minutes doing a face-to-face controlled substance checkout. I just want to be honest with you about that. If you're an officer at a station that has a med unit, you're probably probably once to twice a month when you have medications delivered, it's going to cost you a little extra time, because whoever delivers the medications will be doing a face-to-face check-in of the medications into the safe. And so you'll receive a supply of morphine or Versed, and if that's Chief Wade bringing it out, he would sign that over to you. You would sign it into the safe. And then if you need to get some more morphine because you used some on a call, when you get back to the station, you go to your officer and say, I need to refill 2 vials out of the safe onto the med unit, and you would do a sign in, sign out right there.
Can the paramedic coming on just come to the bedroom and...
I know that's going to be. I know it's a problem. It means that you're going to have to do the face-to-face checkout at 6:30 with shift change. You got something? Structure fire? All right. All right, I'm out of here. I'm going.
So the paramedic's going to have to get up, you're saying?
Yes. Yeah, I mean, unless the fire department develops another way to do it, which I don't know of. I'm saying that from my perspective, well, not just from me, from an administrative perspective, there's got to be a checkout. Now, whether that happens at 06:30, 06:45, I don't know. But the dilemma would be is, if you're coming on duty and you catch a call, then you've taken off without doing a checkout, and then you use some of those controlled substances. Now, every once in a while, that could happen anyway, because you could walk right in and get a call at 6:31 and not have completed your checkout. But yes, I think the checkout for the most part is going to happen at 6:30. The other thing this has caused us to really look at is the utility of carrying benzos on engines and trucks, or in backpacks in general. And interestingly, as we called around, we found only 3 systems that I know of so far that carry benzos on engines and trucks. And that Frisco does, Fairview does, and Allen does. Allen carries paralytics, nuclear weapons, blow dart guns, and everything else too. Those are the 3 that we found. Almost every other fire-based EMS system and non-fire-based EMS system we talk to doesn't carry benzos on engines and trucks. So what you will most likely see is Versed removed from the backpacks and just carried on med units. So it would just be at med unit houses. So I'll answer some questions about, is that safe? Are we going to cause harm by taking those off? I've got another presentation in a minute on seizures, because I think that's probably everybody's primary concern. Am I going to have to watch people seize because I don't have Versed? So I'll try and answer some of those questions. So that's the model we'll most likely follow.
Why is it so hard to keep Versed on engines and trucks?
Because it's a controlled substance also. We would have 23 apparatus to kind of have to plan for rather than 7. It can be done. It's a lot of extra work. So as we're looking at the workflow with this, let me tell you about the considerations we've had. We've considered not carrying any controlled substances and going back to treating pain with Tylenol, Motrin, and maybe IV Toradol. I mean, when you look at how much work this is, okay, we got to spend $14,000 minimum on safes. The amount of man hours that we spend and will spend on this process, you got to look at all options. So, we consider not carrying any controlled substances. However, I think it would be unconscionable to let people seize and very difficult ethically to drive a burn down to Parkland and not have anything to treat their pain. So I think, we're going to bite the bullet and do the work. But at the same time, when you call most EMS systems in the area and you find that very few are carrying benzos on engines and trucks or narcotics. I know we're not carrying narcotics on the engines and trucks. And you look at the amount of work involved, and you look at the system and say, do we have long transport times or short transport times? I think it's reasonable not to. This is the form I fill out every year to reapply for a DEA license for each station. And so we're going to go over a diversion case from McKinney just as a case example. This happened in 2005 going into early 2006. So most of you are here for this, but I don't think it was actually ever formally covered with you. So these are some other case examples. So let's know two terms. There is a loss and there is a diversion. Okay? A loss is just that. A drug is lost. A diversion is known malintent use of a drug. So diversion is me taking some morphine and selling it on Craigslist. Me taking some Versed and injecting a friend who has insomnia so they can sleep. It is me adulterating the medication by removing Versed and injecting saline in there. Even if I wasted the Versed, now we've completely altered the way we're treating patients. So those are felonies, and DEA and Chuck Norris will come swooping in on those with the intent to prosecute. All right, then that's diversion. Then there's loss. So we had a loss last year. We lost a Versed, right? And so you guys may have heard about that or been involved in that. That is not necessarily from the Fed's perspective a prosecution. That is, we've got to have a process in place, as does every EMS system, and we've got to follow that process. So just to be transparent, what happens if we lose a controlled substance? We're going to do an investigation. We have to. It's not like we're being mean. We have to have a process. If we don't have a process, the feds come in and the DSHS comes in and says, you don't get to carry them anymore because you don't even have a process. So our process is we're going to get in touch with everybody that was involved that day at that station in any way possible and interview them. And then if we can't find it, our process, as every other fire department, is we self-report to the Plano Police Department. So they do an objective third-party investigation. If they can't help us find it, we self-report to the DEA and the DPS and the DSHS and say, we lost some Versed. Here's the process we followed. We cannot find it. We have no evidence of diversion. We're sorry. And it's not a 3 strikes and you're out game per se, but it's sort of a strike. I mean, so if they watch for patterns of behavior, if there's a lot of strikes, they're going to start coming to do visits and looking at the process very closely. If it's something that happens once every 10 years, we're sorry it happened. This is our process, and we're going to see what we can do to tighten it down, kind of thing. So, just wanted to use the terms loss and diversion. We had a loss. I'm going to give you an example of a diversion here. Okay. So December 21st to 24th of 2005 in McKinney, Texas, they stored their expired controlled substances in the main storage facility. They noticed that their fentanyl had damaged seals. They immediately reported it to McKinney PD, and they started an investigation. They took all of the vials and they sent them to a lab. All the fentanyl vials were filled with normal saline, not fentanyl. So they had 63 vials of fentanyl that were normal saline. And so they then started an internal investigation with McKinney PD. They coordinated with the DEA, the DSHS, and the Texas Rangers. Interviews began, and they swiftly received a confession on January 10th, about 10, 15 days after the process started. So after the action, were the diluted or replaced controlled substances live on our ambulances? Yes. Turned out they were. They were probably injecting patients who had real pain with normal saline and not fentanyl, requiring them to disclose to any patient in the last 6 months that was treated that they had in fact not treated their pain with pain medication, but rather with normal saline due to a drug diversion.
What's the liability involved with that?
A lot. Yeah.
It was a placebo.
Yeah, yeah. I mean, I don't think they got sued, unbelievably, but you could, and then you just write a check probably. So that was a painful process for them. Weak points, and so this obviously causes some introspection when an event like this occurs. They looked and they said, man, we put all of our medication, all of our controlled substances are expired in one place. It's in a warehouse and it's not locked up. So pretty easy access. They had to educate the crews regarding the seals. They improved warehouse security. They improved med unit security. They improved their documentation. They all quickly took a crash course in federal and state law. And they worked on their verification process. So this was their old system. Whose system does that look a little bit like right now? Right, so look, some of this is something we needed to do anyway. Let's just be honest, okay? It's something we needed to do anyway. So I'm not going to sit here and point and say, oh, the feds are making us do everything, DEA, DSHS. We needed to look at our own process to some extent anyway. The distributorship model, though, is something that we are going to be forced to comply with on a federal level. And it's going to be, I believe, a bit more work for all of us, but not a ton more work for any one person. So here's the new, this is McKinney's new system. I just want to give you one example of what they've gone to. So if you think that if we ratchet up by asking you to do face-to-face checkouts, okay, watch this. Okay, that's lock number 1. That's inside the ambulance. So McKinney doesn't have benzos or morphine or any controlled substance on engines and trucks. You open that lock, you get into there. You bring that out, you got that. You open that up, you got that. You pull that out, you got that. A little bit like a clown car, right? So you get in there and you notice that they've recapped everything too with different colors and stuff like that. So they've got unique identifiers to make sure they're not getting things mixed up. So they've done some neat stuff.
Is all of that necessary to comply with the laws?
No.
Or is it just to lock it up?
No. That is probably a little bit of an overshot because they never want to go through that again.
Yeah.
We don't necessarily have to do that. I'm just trying to give you one example of what's going on 10 miles up the road.
I was going to say, it wasn't too long ago where we did have a locked key box that you had to get into the lock box with the drugs in it.
Yeah.
But that was, I guess, when we thought they had to be double locked or whatever.
They don't necessarily, I mean, and technically, ours are double locked if the med unit is locked, and then you've got the safe. Now, do all med units have the Knox box safes, or is that just Med 6, which used to be Med 2? It's just Med 6? Okay. I think what you're going to see is all of the med units start to have Knox box locks like that, as will all med unit stations have something like that. Again, this is my chance to talk to you guys about this. This is not going to go live tomorrow, next week, or this month, okay? But the next time I teach CE to everybody, I think, is April or May, and it may go live by then. So I want you to understand what's going on behind the scenes rather than just getting an email one day that said, hey, this is our new process. You need to understand why we're going here and some of the reasonings behind it. So what will probably happen is that you'll use your fuel code or some other unique identifier. So you may, if we go the fuel code route and other people know your fuel code, you may want to get a new fuel code. But we'll probably go the fuel code route to punch in and punch out to get medications. Retinal scanners would be cool. The scanner things are very, very expensive. You know, like you think, somebody asked in another class, well, why don't we get one of those Pyxis things that you have in the ER? Those things are like $50,000 or $100,000 that have the thumbprint and that pop out a drawer in the different places. So we're probably going to do some kind of Knox box at the stations too for the controlled substances.
Can we just video surveil those at the time someone's trying to open videos who it is and what they're doing?
It's probably a good idea, and that's not expensive these days, or not as expensive. And then it will record who punches in and punches out also. And the other concept to think about is with controlled substances, our current practice model is say you're on med 10 and then, gets a flat and you switch out and you get the reserve med unit. Well, the controlled substances on med 10 would go to the shop and the reserve med unit would be stocked. And that can get a little confusing. And that's one of the weak points we found with our Versed loss, was that there had been a med unit switch at some point and it became hard to track. So what we'll probably move to is that when you check out medications at 0630, if you were to swap med units, those medications go with you, rather than stocking an apparatus with a par of controlled substances. It's sort of the medic for that day, and they take them with them and then check them out the next day. The dilemma is that, again, this law wasn't written for us. The DEA says that anywhere a drug sleeps has to have a DEA and a DPS license, and the 222 form for all the controlled substances has to be there also. Well, this, again, was written for hospitals where all the drugs sleep in one place, under one roof. People like MedStar in Fort Worth get around this because at some point that ambulance goes back to the mother ship. All their shifts are, roughly 10 to 14, 16 hours. So their ambulances don't sleep at a station. All of our apparatus stay at a station, and thus drugs are sleeping in 13 or 14 different locations if you include logistics. Does that make sense? Because they stay at somewhere else besides the mother ship, you have to go through all of this. And you're going to come up with a couple models for me, like, why don't you try this? Why don't you try that? Man, we've sat in rooms for days going, well, maybe we can rotate after any of the hospitals and swing by logistics and pick up medications. But the fact is, if you got a medication on a fanny pack or a med unit or an engine or whatever, and it goes out to threes, and it stays out at threes, it's got to have all of this stuff out at threes. It goes with it. Otherwise, you'd have to leave all the medications at one building and run to that building and get them before you went on the call. Does that make sense? Yeah. Not written for us. So we'll work on the legislation in the meantime. But I wanted you to understand some of the whys and that are coming down the pike here. So I think it's going to be a few more minutes for station officers. Chief?
You mentioned that we had one Versed loss so far.
Yes, sir.
We reported to me a couple days ago we had a second.
Yeah.
We've got two out there.
Yeah, and so you got to understand from our perspective as administrators, we have to have a process to find this stuff, and when we are expected, when we self-report, to explain what we've done and how we've looked for it, and if we start showing a pattern of loss, then we don't get to play ball anymore. And I don't think any of us want to regress and not be able to treat seizures and treat pain. I mean, we like to practice an aggressive brand of medicine. That's what we do. So, we're going to work on our process. We're a big, busy system, so stuff is going to happen, but we have to have the best process we can.
So are there people actively working on legislation change?
My understanding, I'm on some EMS physician websites, is there was a delegation of EMS physicians from some of the very, very large systems, Dr. Goodlow included, who are going to Washington this month to work on this law. So that was one of the things that Goodlow had mentioned recently.
So 42 years, maybe it'll change?
42? Yeah, hopefully before that. But yeah, it's not going to change this year or next year, but hopefully soon.
Well, I was looking at it a minute ago. It's already been amended for certain situations, so I don't see that obviously getting anything through Washington right now isn't sure, but
yeah,
it is possible.
Yeah.
I mean, they have changed something because we're using drugs they didn't have this ever.
Right. And we're just, medicine has evolved a lot, obviously, since then, and it needs to be a little easier model for how we practice and how we move around. Yeah. All right, well, let's take a break, and then we'll talk about seizures, treatment of seizures with benzos, and whether if we let's talk. We always think, and so we should talk about the worst case scenario. If an engine or truck arrives, somebody's seizing, and you don't have a benzo, is it reasonable for the med unit to be a couple minutes behind, or are we going to leave people to fry their brain? One more thing before you go. I did look at some stats last year. So roughly 12,000 patient contacts, roughly 10,000 transports. we only 5 times did we give a benzo off an engine or truck prior to the arrival of a med unit. So it happens, but it's pretty infrequent that it happens. All right, take a break, and then we'll come back and talk about seizures. We're going to get to the point of talking about them in the context of benzos and carrying them on engines and trucks or not, and just carrying them on ambulances. But I think in general, seizures are a pretty interesting topic because there's a very broad differential diagnosis for what causes seizures. And I think it's been a long time since we've talked about seizures too. Obviously the treatment is pretty straightforward. If they're seizing long enough, we're going to give them some benzos. But I think it's always best to understand what we're treating and a lot of the different causes of seizures too. So we're going to watch 4-ish minute clips about just the general understanding of what causes seizures and the different types of seizures. And then right about the time you're having a drop seizure, I'll flip over and turn on my very interesting self and go over some PowerPoints here. Try and keep you up.
Sounds exciting.
Yes.
Epilepsy affects nearly 3 million Americans, but who is really at risk?
Epilepsy can develop in any person at any age. Almost 1% of people will develop epilepsy during their lifetime. That's 60 million people worldwide. In other words, out of a 60,000 person stadium, about 500 will have epilepsy. New cases of epilepsy are most common among children, especially during their first year. The rate of new cases gradually declines until about age 10 and then becomes stable. After age 60, the rate starts to increase again. Many famous people in history had or may have had epilepsy, including world leaders like Julius Caesar, writers like Lewis Carroll, who wrote Alice in Wonderland, artists like Vincent van Gogh, and athletes like Chanda Gunn, goaltender for the U.S. Olympic hockey team. The causes of epilepsy can be divided into 2 groups: brain injuries and chemical imbalances in the brain. Anything that injures the brain can lead to seizures. But in over half the cases, no cause can be identified. The type of injury that can lead to a seizure is age-dependent. Seizures in children often are caused by birth traumas, infections such as meningitis, congenital abnormalities, or high fevers. Seizures in the middle years commonly are caused by head injuries, infections, alcohol, stimulant drugs, or medication side effects. In the elderly, brain tumors and strokes cause a higher proportion of seizures. Not all seizures result from a structural problem in the brain. Chemical imbalances also can cause seizures. Common chemical imbalances that can produce seizures include drugs like alcohol, cocaine, and others, low blood sugar, low oxygen, low blood sodium, or low blood calcium. Kidney failure or liver failure can also produce seizures. Doctors will evaluate you for these imbalances by taking a careful history and doing blood tests. Although these disorders and injuries can explain many cases of epilepsy, often the cause of epilepsy remains idiopathic, which is the medical term for unknown. About half the time, no cause for a seizure can be identified. Fortunately, we do not need to know the cause to treat the seizures. Scientists increasingly recognize the importance of genetic factors in the origin of epilepsy. Genetics or heredity are most relevant to generalized seizures, including absence, generalized tonic-clonic, and myoclonic seizures. Defects in genes don't lead directly to epilepsy, but they can alter the excitability of the brain in a way that predisposes it to seizures. Typically, epilepsy develops because of multiple gene abnormalities or a gene abnormality in concert with an environmental trigger. Parents with epilepsy wonder whether their children will have epilepsy. In most cases, they won't, but they do have a higher risk than others. If the mother has a generalized type of epilepsy, the child's chance of having epilepsy may be as high as 5 to 20%. But if a parent has epilepsy due to a brain injury, the child's chance of having epilepsy is only about 5%. If you or someone close to you is suffering.
So epilepsy is pretty common. It's more common than I thought it was. All right, let's see. Boom. A little more background on epilepsy here.
A seizure is the symptom of many different disorders that can affect the brain, not a disease in itself. In centuries past, the word seizure referred to people being taken over by supernatural forces.
Today we understand that a seizure is not a supernatural entity. It is simply a medical condition in which too many brain cells become excited at the same time. The brain is an electrochemical machine. Nerve cells, or neurons, use chemical reactions to generate electricity like a very complex battery. When a neuron becomes excited, it passes an electrical signal along its thin biological wire called an axon to communicate with other neurons in the brain. Those other neurons either can be excited or inhibited by the signal. When too many neurons become excited all at once, then a seizure can result. So a seizure is like an electrical storm in the brain. During this abnormal electrical storm, the involved parts of the brain cannot perform their normal tasks, and people experience sudden alterations in movements, sensations, awareness, or behavior. A seizure typically goes on for a few seconds to a few minutes. The end of a seizure is a transition back to the individual's normal state. Because the word ictus is Latin for seizure, this period of recovery is referred to as the post-ictal period, which can last from seconds to hours. A person's level of awareness gradually improves during the post-ictal period. Doctors often are asked what the difference is between a seizure and epilepsy. To the medical community, epilepsy is the condition of having spontaneously recurrent seizures. That means that one isolated seizure is not defined as epilepsy. There must be 2 or more seizures, or at least one seizure with a high chance of having another. To count as epilepsy, the seizures have to appear spontaneously without an immediate precipitating factor. For example, if Johnny falls off his motorcycle, hits his head, and has 2 seizures on the scene, it is not epilepsy because the seizures were immediately precipitated by head trauma. However, if he recovers, then starts having seizures weeks, months, or years later as a result of the traumatic brain injury, then that does count as epilepsy. The word epilepsy has a long history of social stigma, but epilepsy is nothing more than a brain disorder caused by uncontrolled, excessive, and synchronous electrical activity. If you are concerned that you might have epilepsy.
So I would encourage you to think of epilepsy as basically like AFib of the brain, right? It's just, AFib is just abnormal electricity in the heart. Normal person, they just got bad luck. They got some bad wiring there. Epilepsy is very similar. It's a normal person, they just got some abnormal electricity in the brain. All right, now we're going to look at we're going to look at partial seizures and then generalized seizures.
Partial seizures, which involve an electrical discharge in a limited area of the brain, come in a variety of forms. Let's look at some common types.
A partial seizure begins with an electrical discharge in one limited area of the brain. How a partial seizure affects someone depends on whether it is a simple partial seizure or a complex partial seizure, and where in the brain it occurs. Different parts of the brain control different functions. The cortex, or thinking part of the brain, is divided into 4 lobes: frontal, temporal, parietal, and occipital. Other deeper brain structures relate to life support functions, movement, and other semi-automatic behaviors. At the back end of the frontal lobe is the motor strip, which signals muscles to move. A seizure in this part of the brain will cause uncontrolled movements or twitching, lasting for a few seconds to a few minutes. Towards the top of the motor strip are nerves controlling the leg muscles, lower down are nerves controlling the trunk, then the arms, fingers, face, and mouth. If a seizure spreads along the motor strip, the twitching can march along the different parts of the body. Just behind the motor strip is the skin sensation area. A seizure here will cause tingling in the affected part of the body. However, tingling in the skin usually is not due to seizures. The back lobe of the brain is the occipital lobe. It contains brain cells responsible for vision. Seizures in the occipital lobe can produce flashing lights, shimmering lines, or visual hallucinations. The temporal lobe is the part of the brain most prone to develop seizures. It is responsible for many complex activities, including the formation and retrieval of memories and the control of emotional states. If a temporal lobe seizure spreads to both temporal regions, then the manifestation of the seizures increase, with a pause in ongoing activities, confusion, temporary memory loss, and fragmentary, automatic, robot-like behaviors. This type of seizure is called a complex partial seizure. It is the most common type of seizure in adults. In general, when awareness, memory, and consciousness are preserved during the seizure, then the seizure is called simple partial. However, if any are impaired, then the seizure is called complex partial. Someone experiencing a complex partial seizure lives in a moment-to-moment world. During this time, he or she may repeat the same phrase or action over and over in an automatic loop, not recognizing the repetition. This person also may fumble hands, smack the lips, or grab tightly onto things during the seizure. This automatic activity is called an automatism. Others just freeze in place and stare blankly, with no automatisms and hardly any movement. After a complex partial seizure, people don't remember what was said or even what they did during a seizure. Some don't remember having a seizure at all. Later, the memory starts working again except for a gap during the seizure. Understanding what occurs during a seizure begins with the insight that there are.
Anybody seen a partial seizure in a conscious person? So a simple partial seizure where they just arm or just face or just leg, but they're still conscious, versus a complex partial, so they're unconscious, but only part of their body's moving. I thought the motor strip piece was interesting, so you can almost map out where in their brain it's hitting. And then the last one, because I know you're about to have a drop attack here, just 4 minutes on generalized seizures. They got a couple. What those pictures are from is they'll actually have seizure wards in major hospitals, and they'll have cameras in those rooms so that they can catch them. Because a lot of times the patient will be brought in and the family says they're having a seizure, but the neurologist can never see it. It's just like, you know, when somebody comes into the ER or they call 911, they say, man, I'm having palpitations. And it sounds like they had SVT or AFib, but when you catch them, they're in sinus rhythm. Same thing with a seizure. They want to, so we put them, if it's a heart thing, we put them on a Holter monitor for 3 or 4 days and try and catch that arrhythmia. If it's a seizure thing, sometimes we'll put them in the seizure ward with a camera on and try and catch it. And so they can see what kind of seizure it is, because the medications that they get put on change depending on what kind of seizure it is. All right, last one. You're almost there.
Generalized seizures, which involve a widespread electrical discharge across both sides of the brain, come in a variety of forms. Let's look at some common types.
Generalized seizures are characterized by synchronous electrical activity throughout the brain. But each type of generalized seizure has a different effect on people. Here's a typical story from the parent of someone who gets tonic-clonic seizures, which were once called grand mal seizures.
These seizures only last a minute or two, but it seems like forever. It begins with an unnatural shriek, and she falls, and every muscle seems to be activated. Her teeth clench. Shortly after she falls, her arms and upper body start jerking, while her legs remain stiff. Finally, it stops, and she falls fast asleep.
A tonic-clonic seizure is what most people think of when they hear the word seizure. Although these seizures are distressing to watch, the person having them is unaware. We don't believe that the seizures are painful, but people can injure themselves by biting their tongue or straining their muscles. The tonic or stiffening phase comes first. All muscles stiffen. Air being forced past the vocal cords causes a cry or a groan. The person loses consciousness and falls down. The tongue or cheek may be bitten, so bloody saliva may emerge from the mouth. The person may turn blue in the face. After the tonic phase comes the clonic or jerking phase. The arms and usually the legs jerk rapidly and rhythmically, bending and relaxing. After a few minutes, the jerking slows and stops. Bladder or bowel control sometimes is lost as the body relaxes, leading to incontinence. Consciousness returns slowly, and the person may be drowsy, confused, agitated, or depressed. Sometimes seizures don't have tonic stiffening and clonic jerking sequence, but are tonic only or clonic only. Absence seizures used to be called petit mal seizures. Here's a typical story. Frank, a young man, often blanks out for up to 20 seconds at a time. During a seizure, Frank doesn't seem to hear anyone. He blinks repetitively, and his eyes roll up a bit. During shorter seizures, he just stares. Then he continues, as if nothing happened. Some days Frank has over 50 of these spells. Absence seizures usually begin between ages 4 and 14. They can resemble episodes of daydreaming. If they go on for more than 30 seconds, or if there's a lot of movement, then the seizure is called an atypical absence, which is harder to treat. Here's a story from someone who gets myoclonic seizures.
Each morning, I get these jumps. My arms fly up for a second, and I often drop what I'm holding. Sometimes my mouth shuts for a split second. Once I've been up for a few hours, the jumps stop.
Myoclonic seizures usually last only a second or two. There can be just one jerk or a series of several. Consciousness may be lost, but seizures are usually so brief that it's hard to tell. Here's a typical story from someone whose husband has atonic seizures.
When Bob has a drop seizure, he falls to the ground and often hits his head and bruises himself. Even if I'm right next to him and prepared, I may not catch him.
The sudden loss of muscle tone during an atonic seizure can cause the head to drop suddenly, objects to fall from the hands, or the legs to lose strength. This type of seizure is also called an akinetic seizure or an epileptic drop attack. If you have or think you may have one of these.
So, one of the things I learned in residency is that the differential diagnosis for seizure is incredibly broad. Almost any reason somebody calls 911 could be a seizure. Maybe that car wreck, well, they didn't know why they got in a wreck. Maybe they had a seizure. Maybe that syncope was a drop seizure. I mean, and the thing is, they're pretty frequent. They're more frequent than I thought. You saw the example of, given 60,000 people in a stadium, that quite a few of them would eventually, at some point, develop epilepsy. It's because it's an electrical abnormality. And we're all, if you consider our body a house, as the house ages, the electrical system starts to go a little bad. Everybody's going to go into AFib at some point in their life. This is whether something else gets you first. As men, we're probably all going to get a prostate issue at some point. It's just whether something else gets you first. And the same thing is, you're eventually going to have a little bad electrical wiring in your brain too. So seizures are very common. That's the point I'm trying to get across. And then we'll weave our way towards talking about benzos as the treatment. These are the types of seizures we talked about. Now, many of them aren't going to require treatment. I mean, we're not going to go up and give somebody Versed just because they had a drop seizure, or if they had a myoclonic seizure, they don't necessarily need Versed. We're talking about giving benzos, Versed specifically, to folks who are having seizures that continue on our arrival. Secondary causes of seizures. This is where you got to think a little bit and think about the right questions to ask and the different things that could cause it. Because things that you pick up on and clue into on the scene are really going to help me. You get some history and see some things that I'm never going to be party to because I'm in the cocoon of the ER. So trauma, that one's pretty obvious. Intracranial hemorrhage, somebody has a bleed, they're going to have pressure in their brain, they may seize. Eclampsia. So the obvious eclampsia is somebody who's 34 weeks pregnant, they're obviously pregnant and they seize. The less obvious eclampsia is when you enter a house and there's a woman seizing and then you hear a baby crying in the other room. Because you can be eclamptic up to 2 months postpartum. So It's not just while you're pregnant, it's up to 2 months after. And that changes the treatment. You're still going to give Versed, but I'm probably going to hit them with magnesium in the hospital if they're either pregnant and seizing or postpartum and seizing. And magnesium is really the first line treatment for that. I thought about putting magnesium on all the ambulances, but we did a retrospective search, and there's only one case of eclampsia that I could find in the last 4 years. So I didn't feel that it hit the threshold of carrying the medication, given relatively short transport times. If we were a system with 30-minute transport times, I would probably want to stock it because I wouldn't want to leave you with an eclamptic female that long. Hypertensive encephalopathy. So I haven't seen this personally, but theoretically, and I think others I work with have seen it, you have such an amazingly high blood pressure that you seize. I don't know what that exact number is, if it's 270, 300, something crazy like that. I haven't seen anybody seize directly from high blood pressure. Now, if you pop a vessel in your brain because of hypertension, I've seen that. Any mass lesion in the brain has the potential to cause pressure and then cause seizing. Other secondary causes, so toxins and drugs will cause seizure. Anoxic or hypoxic brain injury. So that is a bad prognostic sign if we have say we have a CPR save. We get a pulse back on somebody. We're chilling them. They make it through the ER. They still got a pulse. They go up to the ICU. They drop their core temp to 90, 91 degrees. And then they keep them there, and then they rewarm them. And during the rewarm, they'll start to wean the sedative and the paralytic. And as you wean the sedative and the paralytic, if the patient starts to breathe on their own and overtake the vent, that's a good sign. If the patient doesn't breathe on their own and they're just continuously seizing, that's a bad sign. That means their brain took a big hit for a lack of oxygen. Metabolic disturbances, things that you can think about and look for. Everybody in here can check for hypoglycemia as a cause of seizure, as a common cause of seizure. Hypo or hypernatremia, that's sodium. It's just a doctor word for sodium. So extremely dehydrated nursing home patients often get very hypernatremic. If the normal range is a 135 to 145 with sodium, I've seen people come in as high as 150, 160, 170, and they'll seize. And on the bottom end of the spectrum, that's where someone in our age group could get caught. Say you have hypertension, you just got started on hydrochlorothiazide or Lasix or another common diuretic. In a small percentage of folks, the week after they start it, their sodium will go, it'll just affect their kidney in such a way they'll dump all their sodium. So if somebody if you find somebody seizing and their spouse says, oh, they just started Lasix this week, or hydrochlorothiazide, which is even more common, HCTZ, that'll cause hyponatremia. Extreme hyponatremia causes seizures. Hyperosmolar states is just a fancy word for being extremely heme concentrated or dehydrated. So you got sludge in your blood. And then uremia and hepatic failure will cause seizure. Uremia is kidney failure. So if a dialysis patient doesn't dialyze for a couple of weeks, they may build up enough kidney waste product to seize. If a cirrhotic patient, liver failure patient, if their liver is not clearing out ammonia, they'll develop enough ammonia in their brain, they'll become encephalopathic or real goofy and sedate, and eventually they might seize also from that. Status epilepticus is, by definition, continuous seizures for a certain amount of time. There's a bit of debate about how much time that is, but the general consensus is about 30 minutes. So that can be 30 straight minutes of seizing, that's what we all think of, but it can also be in combination. If you had 3 10-minute seizures in one day, that would be considered status also. I think the reason we coalesce around 30 minutes is as best I could research, the general neurologist consensus that's when brain injury starts to occur from continuous seizure. So putting that in the context of, is it okay to take benzos off of engines or trucks where somebody may seize a little bit longer? Medically it's safe. Yes, it's uncomfortable if you're on an engine or truck to have to watch somebody seize a bit longer. Medically it's reasonable, and that's why I think many systems don't carry benzos on engines and trucks. Now what it would necessitate, and Whitehead and I were talking about this, is if even though I told you only 5 times in 2011 did we use Versed off an engine or truck prior to the arrival of a med unit, there are probably, like you said, many times where the med unit medic got off and was handed Versed from the engine or truck. So if that goes away, what it will necessitate is more communication of, hey, grab the Versed the minute you get off the ambulance because we're going to need it. That's probably not the you haven't had to have that conversation previously because you could just grab it off the engine or truck. Questions to ask during history, because again, you may run to Frito-Lay and find somebody having a seizure, and so the historians are going to be the people at work who are not necessarily going to come in. And so I'm going to be asking you, I want you to know the questions I'm probably going to ask you to see if you ask the people at work. You know, so Bob's given a PowerPoint presentation, and then he starts to look around funny, and then his arm starts to dance. And then he goes into a full generalized seizure. I'm going to ask you, hey, how fast did it come on? Did they tell you? Did Bob complain of lightning or hearing funny things? And did Bob do like a dance with just one part of his body before he broke into a generalized seizure? Was Bob incontinent? And so the thing is, for some reason, there's a percentage of the population that will have pseudo-seizures, which is just a nice word for fake seizures. And I've told you this before, but I'll never forget I've seen pseudo-seizures, but a lady I had in residency that I called her out, I said, you're having a fake seizure. And she got angry with me, stopped seizing, and got up and left, and then walked out in the street and got hit by a car and died. She came back as a trauma. So it's a rather sad event, but felt bad for calling her out. I should have just let her fake seize. But she was pregnant too. It made the news. It was really bad. Really bad. But there's some secondary gain issues with people that we'll never understand. There are people that fake kidney stones and will cut themselves and put blood in their urine just so they can get narcotics. So I'm putting this all in the context of very few people will fake incontinence. Okay, so if they urinated or defecated on themselves, it's probably a real seizure, or they're really motivated. One of the two. If they bite their tongue deeply, probably a real seizure. Okay. Duration of the episode and whether there's a post-ictal. All real seizures have a post-ictal phase. Okay. If somebody kind of, they're sitting in there, and then you come in the room, they start going, and then you say, you know, stop or something like that, and they go, huh? Then that's not a real seizure. Okay, all real seizures have a post-ictal phase because this is a massive electrical discharge from the brain. Okay, it's like running a 1,000-yard sprint, and people are exhausted afterwards. So usually people, after they get done seizing, are maybe a little twitchy still, but they don't interact normally. If they completely come back to conversation, I'm having a hard time buying it was a real seizure. Okay, so ictus means seizure, post-ictal means after the seizure. So how long were they post-ictal? Now, febrile seizures in kiddos have a very brief post-ictal phase where they'll hypoventilate. Scary looking, scares me every time, and I've been doing it for a decade. Some of y'all have been doing it even longer, and it probably still bothers you when you see a febrile seizure. It would terrify me. I got 3 kids. I'm an ER doctor. I'd still take them to the ER if my kid had a febrile seizure. It would freak me out. So I never give a parent a hard time if they come in with a kid with a febrile seizure. Usually the prognosis is very good. We'll talk more about that. So febrile seizures, typically brief post-ictal phase. Generalized seizures in adults, longer post-ictal phase. Contributing factors. Sleep deprivation is an incredibly common cause of seizures in otherwise healthy people. If you work 2 shifts back to back and then go home and take care of the kids all day and never sleep, and then try and take your spouse out on a date and then seize on that date, it's probably because you worked and never slept for a couple days. Okay, so you got that college student who's been drinking rock stars because they got a test tomorrow, and then they try and go out after the test and they never slept. Everybody has a seizure threshold. This is just abnormal electricity. You lower your threshold to seize when you don't sleep. Okay, so just keep that in mind because that's a very common cause. Alcohol withdrawal is probably the most life-threatening cause of seizure. So look at the scene. If there's Jack Daniels left and right, then that you have to consider the cause of seizure as alcohol withdrawal. Very life-threatening. Will probably take all the benzos on your med unit to help stop that seizure. They chew through benzos pretty heavily. But with all alcoholics who are seizing, the other thing you have to think about is chicken or egg. Did they seize, fall, hit their head, and now they have a brain hemorrhage that's causing them to seize? Or were they drunk, fell, hit their head, and they're having a brain hemorrhage and seizing? Or is it a DT type of seizure? So every intoxicated patient who is found down, unknown etiology, I'm scanning their head 100% of the time in the ER. Just too many times that we miss stuff. Classic ER malpractice stories are the drunk who was just put back in the corner to sleep it off that was found down and then is found dead the next morning of a subdural. So if that drunk can't talk to me and is found down, then they're getting scanned every time. Infection in the central nervous system like meningitis or encephalitis, they're getting an LP every time they come to the ER if they seize. Okay, so if you got a new onset adult seizure and they got a fever and a seizure, LP practically every single time, all right? Looking for meningitis, encephalitis. Meningitis and encephalitis are the same thing. Encephalitis is brain inflammation from an infection. Meningitis is meningeal or spinal cord inflammation, and that's all connected. And then this may come as a shock, but if you stop using antiepileptics, you will probably have a seizure. Okay, first time seizures, we talked about the workup. So you're going to get a head CT most likely. If you have a fever and a seizure, you're going to get a spinal tap. You're going to get some labs looking for sodium, glucose, and other things that are out of whack. We're going to give you some IV fluids. You got to assess the patient for injury. 5 to 10% of patients who have a seizure have some secondary injury like a broken bone or a dislocated joint, because these, particularly the generalized seizures, are very powerful. It's a complete electrical discharge from the brain. Bam, 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 bam. I've seen multiple shoulder dislocations in seizure patients, and it's easy to miss. It's human nature to hone in on the most obvious thing. Just as an aside, an example, I treated a gal the other day, and she had a dislocated finger where she was standing over here and could have been pointing at you over there because this finger was on sideways. She'd fell and hit her head, her face was all messed up, and this finger was on sideways. So I scanned her head and x-rayed her finger. Well, I forgot to look at her other hand where she had a broken finger. I called her back, I got her to come back and reassessed her, but it just reminded me, human nature is to look at the obvious. Remember, if you have a seizure patient, that you got to do an assessment of their entire body to look for broken bones and dislocated joints and stuff. Tongue lacerations, pretty hard to fake. You had a real seizure if you bit pretty deeply into your tongue or you're very motivated. And then Todd's paralysis is, for me as an ER doc working at a stroke center, a risk, because that's the #1 cause of mistakenly giving TPA for a stroke that's not a stroke. So Todd's paralysis is seizure that upon reawakening has a focal neurologic deficit. So somebody has a generalized seizure, then they have a postictal phase, and as they're coming out and waking up, they're still not using their arm or not using their leg or have a facial droop. So one of the exclusion criteria for TPA at a stroke center is seizure at the onset of a focal neurologic deficit. So if you hear seizure on scene and they look like a stroke, it could be Todd's paralysis. Probably not going to TPA them. Couple of cases, just to stoke your brain, they should be relatively straightforward. 14-month-old, feels warm, seized for 30 seconds, or episode of shaking described by the parents, stopped by the time you get there. What'd they have? Febrile seizure, right? Typically, it should be done by the time you get there. If they're still seizing, and it's a 6-month-old, a 1-year-old by the time you get there, they're already bridging into the land of what we call a complex febrile seizure, because that probably means they've had a febrile seizure for over 5 minutes by then. Most of these should stop after 1 to 2 minutes. The age range typically is 3 months to 5 years. You're looking, I'm looking for an underlying cause as an ER doc, so I'm going to maybe do a urinalysis. If it's flu and RSV season, which by the way, RSV is really kicking in right now. We haven't seen flu yet, but we're getting a lot of RSV positives in the ER in the last week or two. So that's the age range for febrile seizures. The treatment is pretty straightforward. It's just lowering the fever, looking for a source to treat if it's pneumonia, flu, etc. And just know that family history, this is heritable. If I had febrile seizures as a child, my children would be more likely to have febrile seizures. And once a child has a febrile seizure, they're more likely to have another one. All right? Scary stuff. But almost uniformly has a good outcome. And that's the thing I try and sit down and spend 5 minutes talking to the parents about, is it doesn't mean your child's going to have epilepsy. There's very, very little, there's a little bit, but very little increased risk of epilepsy if your child has a febrile seizure. But they may have more febrile seizures until they kind of grow out of that age range. And it's just, you've got some brain irritation because the temperature center in the brain is not too far from the area that causes seizures. 19-year-old healthy female, breastfeeding newborn, and has a tonic-clonic seizure while she's feeding the newborn. So what did I just tell you that this one might be? Eclampsia, right, right. So not just for pregnant women, can be postpartum also. Up to 8 weeks postpartum. So pre-eclampsia, you can also have pre-eclampsia postpartum. That is 3 things. That is high blood pressure during pregnancy or right after pregnancy, protein in the urine, proteinuria, and then edema of the hands, feet, face, etc. It bridges from preeclampsia to eclampsia when they seize. You treat with Versed. I'll throw in some magnesium. 50-year-old male with a tonic-clonic or a generalized seizure lasting 2 minutes. He's on Tegretol. What? He's an epileptic, right? He's a known epileptic. That's an anti-epileptic that he's on. So I'm going to give you some buzzwords that you don't have to memorize, but just so you hear these when people say them, because I'm going to check levels of these when you bring the patient in. Everybody's probably heard of Dilantin. It's also called phenytoin. That's probably the oldest anti-epileptic. Then there is phenobarbital. Not so commonly used anymore, but still sometimes. There's Tegretol, which is also called carbamazepine. That's the generic word for it. And there's Depakote. The generic for that is valproic acid. Those are kind of the first, second generation anti-epileptics. Then there's a new one out called Keppra, which is also called levetiracetam, I believe. And that's becoming more and more common because it has less side effects than some of the first and second generation anti-epileptics. Epileptics generally don't like taking their medications, and it's understandable because of the side effects. They're sedating. Some of them, like Dilantin, cause some gum and teeth issues that they don't like. And so there's certainly some compliance issues. So if you say, Doc, they had a seizure and they're on X, I'm going to check a level of X. If it's subtherapeutic, I'm going to load them with X while they're in the ED. And then I've got to give them the warning that they don't like, which is you can't drive. You can't drive until you follow up with a neurologist, and if it's a first-time seizure, have an EEG. That's the caps that they were wearing in all those videos, that if you looked, there was a little cord coming out of the back of the cap. It's an electroencephalogram. It's like an EKG of the brain, essentially, and it looks at the brain waves and the different lobes to determine what kind of seizure it is. So they've got to follow up, see a neurologist, get an EEG, and then potentially start on some anti-epileptics. If you have one seizure and you have a normal EEG, you get a mulligan typically, and you don't start anti-epileptics. Once you have your second generalized seizure, you typically do start anti-epileptics. Or if you have one seizure, you go to the neurologist and you have an abnormal EEG, you typically start anti-epileptics so that you can drive again. "34-year-old male with history of alcoholism is found status post-seizure. Patient is confused and combative and vomiting." What are we thinking with this guy? DTs. Okay. So this is an advanced stage of alcohol withdrawal. Some people, when they withdraw, they get a little shaky, they get irritable, they get headaches, etc. You have to be pretty hardcore for a pretty long period of time to actually seize when you stop drinking. So if you pick up somebody and they're intoxicated and they tell you they have DTs, are they going to seize then? No. When are they going to seize? When they're sober. So if we pick them up and their alcohol level is 240 or 0.24, depending on how you read it, the body clears alcohol at roughly 30 milligrams per deciliter per hour. So if their level is 240, they're going to be at an alcohol level of 0 in about 8 hours, 240 divided by 30. And so if you bring me somebody and they're drunk and fell and hit their head, right? And I scan them and there's not a head bleed, and we decided we're going to admit them to the hospital. Well, I'm not worried about them seizing right then. I'm worried about them going upstairs and seizing in 8 hours, and seizing on the floor if nobody's watching them, because they told me they got a history of DTs. So we actually have an alcohol withdrawal scoring pathway for that. I'll send that up on the orders, so that the floor nurses know to watch for that, and they have written orders for a taper of benzos. As an aside, you've heard me mention before that hospitals and EMS systems are starting to run out of generic medications. We've talked a bit about this. Logistics and I get a weekly update of what medications Boundtree is running out of. So I worked at the hospital quite a bit between New Year's and Christmas, and we're out of IV Ativan, we're low on IV Versed, we're out of IV Valium. So that means that I've got oral Valium and Ativan, and I can give IV Versed if needed. We are starting to run low on etomidate. We're out of IV Levaquin, which is probably the most common IV antibiotic besides Rocephin. IV Benadryl is a bit short, but we still seem to have enough. So I mean, we're talking some incredibly common medications here. We have a pretty good stockpile going right now, but I'm starting to have to learn as an ER doc to be a little bit resourceful with what medications. We're out of IV Compazine, the most common anti-migraine medication given IV. We're starting to have to be resourceful with how we approach certain disease processes. So if you see us shuffling a bit from a medication supply chain perspective, again, it's not because we're trying to make your life harder. It's because the generic drug manufacturers are either going out of business or just choosing not to make certain things anymore because there's a very slim profit margin with generic medications. I don't for the life of me understand why they don't just charge a little bit more. It doesn't make sense in a capitalist model not to do that, but that's beyond me. So this starts after they stop drinking. We're going to be giving them lots of benzos. The patients who have chewed through the most benzos I've ever seen in my life are people who are DTing. Tons. 22-year-old female with 2 episodes of shaking in the last 6 hours. Each shaking episode lasted 5 or 10 minutes, and now she's had another, this time 15-minute generalized seizure. What's she got? Status. So she's in status due to the combination of the 3. We're going to call that status epilepticus. Okay, a few studies about why we went to intranasal Versed. As I was on the seizure topic, I got interested to make sure we're doing the right thing to see if there's anything else out there. Well, the first thing is Ativan and Valium are too viscous to go up the nose. So they're both more of a on the basic side of the pH range and more viscous. Versed is more acidic. It's got a pH of about 3.5 or 4, and it's the most water-like, and so it's the only one that'll aerosolize well. The first one here is a head-to-head study between IV Valium and intranasal Versed, and what we found is that intranasal Versed actually works faster than IV Valium to abate seizures. 6 minutes for intranasal Versed, 8 minutes for IV Valium. Probably some of that has to do with the IV start time. This is from the journal Seizure, and it was just a general efficacy study. The question was, how often does intranasal Versed break a seizure? And the answer was 94% of the time. So that's pretty good. Now this was a head-to-head study between intranasal Versed and rectal diazepam, which works better. Intranasal Versed was effective in 87% of seizures. Rectal Valium broke 60% of seizures. So we have a more pleasant route that works better and costs $2 rather than $140 a dose. So I think it all makes sense. Again, this is a 2007 study from Pediatric Emergency Care, intranasal Versed versus rectal Valium. The intranasal Versed broke seizures 19 minutes faster on average in this study than rectal Valium. And if you look at some of the sequelae or problems from giving rectal Valium, you can see that they're more likely to re-seize, more likely to require intubation, more likely to be admitted to the ICU if they got rectal Valium compared to intranasal Versed. So I think the intranasal route is here to stay, and I think you'll see it as an increasing option with other medications. I've actually been tasked to start to work with the emergency department to implement intranasal medications, because the the hospital always runs 5 years behind what we do in the field. We teach them what to do. And so I think one area that might be interesting to watch, though, is we may, I think in the next couple of years, get into intranasal ketamine for sedation. And you could have a completely needleless pediatric emergency department experience, because you're going to think if your kiddo had a head lack and they're 2 and they're not going to sit still. Right now we have to stick them with a big old slug of ketamine, 4 milligrams per kilogram in the thigh. Now we could potentially sneak up behind them and give them a sniff of ketamine and then repair the laceration or pull the finger back straight. And they never had to even get that big shot or start an IV. So it'd be kind of cool. So that's what I got for you on seizure. You know, our seizure protocol doesn't change. I think it's pretty straightforward. Do you feel that you've got enough access to Versed offline, or do you feel like you're having to call for more Versed online with seizures? You know, we're giving it 2.5 IV, I believe, up to, I should know this, 5 or 10 offline before you got a call, and then in 5 milligram doses up to 10. Is it 2.5 offline up to 5 for IV, and then 5 offline up to 10 for intranasal or intramuscular, I believe? And so is that enough for you guys? Are you having to call for Versed online a lot? It's been okay, rough most of the time? Okay. 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 So in summary, you know, it's reasonable. I'm not going to say it's ideal, but I think it's reasonable to just carry it on ambulances, because what we're worried about is fried brain, which typically only comes with status epilepticus, which is, I would say, minimum 20, more likely 30 minutes of seizure activity. And I am confident in saying we're going to have a med unit there prior to that. Any questions I can answer about seizures? Does anybody want to come up and give an example of a partial turning into a generalized seizure? Okay. We'll give you guys a break here, and then we'll come back and we'll talk about some housekeeping items, and we'll talk about helmets and talk about concussions. As much out of personal sports interest as anything else, but also, I mean, a lot of us are dads, and we coach our kids' teams, or they go, you know, in my case, my daughter cheers for the FFL, and I've seen you up there, so, you know, we'll get asked when kids get knocked out on the field to give an opinion on things. And yeah, I know, that's what has progressed in Frisco. I have a 7.5-year-old that is a cheerleader with a full-on cheerleading uniform.
What he was cheering for. You said
Nichter cheers also. They got, you know, it's just they need a one-man cheerleader on every team. He likes the tight top that he gets to wear with it, you know. He insists on the sleeveless one though. Everything else.
He wears those kids' shirts anyway.
Range of motion. So, anyway, to further devalue my man card, we get asked to look at kids who got their bell rung. That was the old term, right? That was before we paid a lot of attention to traumatic brain injury. And I think you see a lot more attention being paid to it in 2 fields. And one is in sports, where the evaluation of concussions has progressed a lot in the last couple of years via attention from the NFL and doing biopsies and autopsies on former NFL players' brains and boxers' brains, and the growing body of evidence that cumulative concussions is not a good thing for you. And then also in the military realm, I think we're starting to really appreciate what traumatic brain injury can do to our veterans, and the kind of the neuropsychologic effect it has on people when they come back after multiple concussions, and how it affects their daily life. So this is not meant to be an exhaustive review, but just kind of an overview of some of the things going on with concussions. So I would say the first thing, if you're asked to evaluate a player with a concussion, this is as much private life stuff as on-duty stuff, but is you're going to want to get, it's better to do that concussion evaluation on the sideline than right on the field. So you want to get them over there, make sure their C-spine is obviously okay. So you do the obvious things first. Do they have a significant traumatic brain injury to the point they've seized, or they have a neurologic deficit? That's certainly a true emergency. That's not stopping at the sideline to evaluate them. We're going to the ER and loading them up with that one. But if it's somebody who's starting to normalize, has no neurologic deficit, you're going to take them over to the sideline and do a neurologic evaluation. I'm not going to cover this entire questionnaire. I'm just putting it up there to show you that there are now standardized questionnaires that you administer to patients to look for concussion. So this has gotten the beyond, do you remember who you are, can you see who I am evaluation that existed for years. This is based on research, some of which the NFL is now funding, and you can see the backlash that's developed if they don't do a concussion evaluation when you think about the Colt McCoy thing that happened a couple weeks ago with the Browns, where I guess the story is, and tell me if I'm wrong, all the trainers were looking the other way or tending to other injured players. McCoy got lit up by, I think, Harrison, the linebacker for, that is a real friendly guy, the linebacker for the Steelers. And McCoy did not get a concussion evaluation on the sideline and was sent back out there, and it's now believed he probably played the rest of the game with a concussion. And there was, the NFL was looking into the Cleveland Browns process for that, and there was some thought that heads might roll because he got back out on the field without getting a concussion evaluation. So what does a general exam entail? You're going to do a neurologic exam to make sure they have no deficits, to make sure they can answer questions. Then this is the symptom scoring here. You're going to do a GCS. Then there's some questions that you standardize that you go through with them, and there's another assessment of concussion. You check their balance and you check their coordination as well. So is it a concussion? Yes, it's a concussion if they have any obvious signs. They're knocked out, they have a neurologic deficit, or a cognitive deficit, meaning they can't think. You're asking them a question, they're awake, but they can't answer. That's the obvious concussion. And then there's the symptoms. And that's where I've started to, in my practice, more often diagnose concussion without loss of consciousness. We actually have now discharge instructions in our computer for concussion without loss of consciousness. So if somebody comes in to the ER and I see them, because this is a common Friday night or Saturday visit during football season, and somebody has concussive type symptoms. They weren't knocked out, maybe they vomited, maybe they're having trouble recognizing their parents, or maybe they're having trouble walking straight. Maybe they just feel like they're not themselves and they're slow to answer questions. We now call that concussion without loss of consciousness. So it's a diagnosis that's being utilized more. And then the question you're going to be asked if it's the Pee Wee Football League and you're acting as the team trainer is when can they return to play? And the answer these days is almost never can they return to play the same day if they have concussive symptoms. Okay, so that's the safe answer. Really, the gist of this whole talk is the only people in the future who are going to get to return to play after concussive symptoms are professionals, people who are getting paid to do it. And pretty much everybody else is going to get the recommendation they don't go back out there. So there's RTP stands for Return to Play Guidelines. No one returns to play while symptomatic. This is a big paradigm shift for us. When we grew up in Texas, what happened? Get back out there, right? That's what we grew up with. Get back out there, man. It's a new day and age. My parents used to tell me, go play up the street. We'll see you in 8 hours. I don't think I've ever said that to my kids. I'm right there watching them like this now. So it's just one of those things. Athletes must be asymptomatic, both at rest. Okay, so you got to be sitting there without symptoms, with cognition, meaning you're putting them through some thinking tests, and then with exertion. Okay, get up, and we're going to have you run back and forth, and I'm going to make sure you're running straight and see how you act once you actually increase the blood flow to your brain. So they must have normal cognitive function. So this is something that you can use as a scare tactic on parents and coaches, but it is a real entity. It's not common, but it's a real entity. And so that's called second impact syndrome. This is what I describe to parents who have a kiddo that I diagnose with concussion. Much like I tell somebody who's had a seizure, you can't drive until you follow up with a neurologist, get an EEG, and get cleared. If a child has had a concussion, I say you can't go back and play contact sports until you're cleared by your pediatrician or neurologist, because I need them seen again by a professional to document and know that they're asymptomatic before they get back out there. I talked to the parents about second impact syndrome. Much like if you had, if you just broke an arm and then it's healing and then you get kicked in the arm again, it's more likely to break. Same thing with your brain, all right? You get kicked in the brain, you have a concussion, the next day you get kicked in the brain, and again, there's a stacked effect to this, all right? So second impact syndrome is a real entity, and that's why we wait a while before we clear people to play if they've had one concussion. You'll have prolonged symptoms if you have a second rapid concussion after the first one. And so there's a staged return to play. And I would say this is akin to sprained ankle instructions I give to people. If you sprain your ankle and you come to ER, I say, all right, we're going to wrap it up. We're going to give you some crutches, but I don't want you to use the crutches for more than a couple days. Once you can walk in the crutches without pain, put them down and start walking. Once you can walk in a straight line without pain, then you can take your wrap off and you can start to run in a straight line. Once you can run in a straight line without pain in your ankle, then you can go back to playing football or breakdancing or lambada or whatever. Whatever you can do that you sprained your ankle, the first one, right? There you go. Cheerleading. That's right. So the same thing is with head injury. You're not going to go straight from, okay, now you don't have a headache anymore, to go back out and get in your pads. This is pretty much consensus advice that all trainers are giving these days. It is, okay, you're not having a headache anymore. Your thinking seems to be straight. You're answering questions appropriately. So tomorrow you can start walking laps around the track, and we'll see how you do. And if you're asymptomatic, then we'll progress you to running around the track and see how you do. And okay, now you can get out there and do padless drills with the football team, and we'll see how you do. Okay, you did fine with that. Now you can put the pads on. We'll see how you do. It's staged. Is immediate imaging necessary? This really brings a larger question into play too, because the easy thing is to scan everybody's head, but that's not always the right thing to do. I, as a parent and as a person, worry about if we continue to scan every child's head, what's going to happen with their thyroid, which is a very radiosensitive organ, 10 and 20 years down the road. I think we're going to see an increased incidence of thyroid cancer. If you shadow me in the ER, you'll see that I order a lot of scans. It's a great test, but every time I order one, I have to think, is it worth it? Because I'm exposing this patient to some radiation. I left there a minute ago. My wife called me. She's at the OB-GYN. She was having some pain, and the OB said, well, maybe we should just do a CT scan to check you out. And I think that when she called me and she said, do you think I need it? I said, I don't know. I don't know if I want you exposed to that amount of radiation, or if we should just wait a couple days and see. X-ray. Again, I've told you this before, but a flight from Dallas to Austin gives you the same amount of radiation exposure as one chest X-ray. Pretty minimal stuff. Ab-pelv CT, chest CT, it's about 100-something X-rays, okay? And head CT is a little less irradiation, but it's still hitting pretty close to the thyroid. So I'm not going to scan every concussion. If you brought me every concussion that existed out there in the football leagues, here are triggers for things that are going to make me scan somebody in the ED. Prolonged loss of consciousness, anytime somebody has a hit in the head and a seizure, I'm going to scan them. If they have a residual neurologic deficit, they're probably going to get not only a head scan but a neck scan too, because sometimes that's from a spearing injury and they've got a compressed cord. And then anybody who is not getting better over a prolonged period and/or declining, like they could have a good conversation for a couple hours after the concussion, and then they went home and their speech became more slurred, they're going to get a CT too. What are some modifiers, some things that influence evaluation? So here's some examples. If their symptoms last over 10 days, if they lost consciousness for more than a minute, anytime somebody has a seizure, if they have some comorbidities, these are things that are going to trigger active follow-up, like you're probably not going to get cleared. Your kiddo's probably not going to get cleared if you have some of these issues a couple days later by the pediatrician. They're probably going to want a couple of serial visits and/or a visit to the pediatric neurologist as well. The best treatment is really rest. It's just time off, which no athlete likes to hear. Well, doc, I sprained my ankle. How fast can I get back out there? You got to take a break for a while. I got a concussion. When can I get back out there? You just got to take it. It's just forced rest for a little while we evaluate your symptoms. There's not a medication that really makes it get better faster. So anytime you see blanket statements from a major organization, you know that it's probably going to influence management. The American Academy of Pediatrics recommends conservative management, which means no return to play on the same day. So who can go back and play on the same day? Adult professional athletes under certain conditions. And this is being put into rule at both the NFL and the NCAA, where they have to put checks and balances in so the coach can't override the team doctor or the team trainer. There has to be some independence so that the trainer or the doc is not worried they're going to lose their job if they hold somebody out of the game. So adult professional athletes under these conditions, they cannot have lost consciousness, and it has to be relatively mild. The symptoms have to go away within 5 to 10 minutes. They have to have normal neuro testing, and then they have to go through sideline drills, which reveal that they have no residual effects on the sideline drills. And then you have to believe that they're being honest with you, and that's hard because these guys' livelihood depends on them getting back out in the field. Think of the examples this year. If you think about watching the NFL this year versus previous years, it's subtle to pick up on, but if you saw a guy leave the game in the first quarter with the diagnosis of possible concussion, how often did you see him come back later in the game? I'll tell you, I was watching, and the answer was almost never. You see guys, superstars in the NHL like Sidney Crosby, who missed almost the entire last year with a concussion, stepped on the ice this year, started getting headaches, whoop, back off. He's not playing again, and he's probably, if not the best player in the NHL, one of the best players. So I think there's a paradigm shift in sports in the way concussion is being treated, even for the superstars. If you have 3 more concussions, your season is over. This is for professionals. There's a more local example of a guy who probably, under the current rules, would have had many seasons ended earlier. NCAA concussion management. So this is a memo to head athletic trainers from April of 2010. You must have a concussion management plan. You must remove them from practice and evaluate them for any concussive symptoms. No return to play that day. The coach may not challenge the trainer or the team doctor on this. All right. So just a brief ditty on concussions. Anybody have any questions about concussions or been asked to manage them? It's an interesting change from, kind of what we grew up with, but this is another thing that I think is here to stay. There's Big Sammy in his, I forgot to show you that slide. For one brief, glorious moment, you forgot you were on the Cubs. Oh, man, I gave away my money slide there. Oops. All right. This is just some housekeeping stuff, so I'm going to scattershoot a bit. Priority 1 patients. How often do I want you to document vital signs? All right. Yeah. Every 5 minutes. All right. The SOP actually says you got to document vital signs every 5 minutes. So if you're with a priority 1 patient for 20 minutes, I'm just going to clue you in. How many sets of vital signs am I going to look for? 20 minutes.
We're good at math.
There you go. All right. You get the point, though. What I'm seeing is a trend where I'll have 1 or 2 sets of vital signs on priority 1 patients. I need more. I want more because I want to know how they're trending and how that trend affects your treatment. Recertification. So everybody in here has to recert every 4 years. everybody, as long as you either show up to live CE or watch the awesome DVD Makeup CE of me standing up here. I always feel for people who are injured and then have to watch me in volume, like 18 straight hours of me standing up here. But as long as you get your hours in, everybody's going to keep their certification up. But sometimes the state will send you your cert 4 months before it's due. Just call the MCP EMS office first before you send it back, because we got you on a pretty tightly managed regimen of making sure you get the right amount of peds and trauma and specials and all that stuff. And so we need to make sure you've got it all before you send it back. So it's pretty brainless. Just when you get the cert, call us and we'll make sure you're up to date, all right, before you send it back. Sharps clarification, I was a little unclear last time on the Sharps bullet tube. So let me be clear. The disposable bullet that's in the stat pack, when you put a Sharp in there, just throw it away and get another one. Those are $1. Y'all's hands and needle sticks are a lot more important than $1. Okay, so when you throw something in there, throw it away, get you another one. We should be stocking the stations with plenty. If we need to increase the power of those, please let us know and we'll do it. Okay? Putting more than one in there? Good point. That's right. Yeah. Hey, I know. I'm as the protector of the stat pack. Yes, we will have to sit down and have a conversation, but that seems like a very realistic one there. That's right. That's right. All right. That's right. I'll ask the DEA. Here, I was going to send myself an email, but I'll just write it down here. Okay. Extra. Bullet. All right. Paramedic minimum skill set. We have been doing this for a year, and so I wanted to revisit it just to make sure everybody has a clear understanding of what we're looking for. Paramedic in the system is expected to have 1 successful intubation every 2 years. So since the start of January of 2011, you've got until December 31st of 2013 to have 1 successful endotracheal intubation. All right? So then you're good. And it's just every 2 years we're looking for a successful one. You can get those in the field, in the ED with me, or the cadaver lab. So far we have a 100% success rate in the cadaver lab. Seems to be going pretty well in there. So if it comes to December 31st of 2013 or 2012 and you don't have one yet and you're a paramedic, the world is not going to end. You're not going to lose your job. All we're going to do is put you in a position to get one. All right? We're going to bring you to the ED to tube somebody. We're going to send you to cadaver lab to tube somebody. So it's not punitive. What we're trying to do is I think it's ethical, guarantee the citizens of Plano that we can do a certain number of skills successfully in a given amount of time so that everybody just keeps fresh. Something that all the docs at the hospital and PAs and nurse practitioners, everybody else has to do too. 10 successful IVs every year. We should have stats out to you soon if you're a paramedic. If you didn't have 10 successful IVs in 2011, you may get an invitation to come to the ER and start some IVs for a couple hours while you're on duty. Not a big deal. You can probably knock out 10 IVs in 2 hours if you got 0 in the last year. And I think most people got at least a couple. And then 6 shifts on the ambulance for every FRS paramedic. Okay, pediatric transport policy. This one, it hurts a little bit, but I think in the spirit of being honest and fair, it's the right thing to do. There's trauma and there's medical. We're going to stop transporting medical pediatric patients to MCP. Okay, MCP recently stopped admitting kids. I got about a day or two's notice on this. And so I've been kind of hanging back and waiting and see how some things played out. But I believe it was an understandable economic decision for the hospital because they're turning down 80 to 100 adult transfers in a month from outlying hospitals for stroke and trauma type stuff. And they had probably an average census of 2 to 3 pediatric patients on their entire pediatric floor. And so the hospital administration has chosen to repurpose that floor for adults. That affects me as an ER doc. It affects us as pre-hospital emergency care providers because I don't think it's fair to take a child to a hospital that can't admit them and is going to have to transfer them and incur then a second transfer charge. So this policy will be out to you soon in written form, but I don't mind if you go ahead and put it into play today. What will come out is a transport matrix, you know, the thing that makes you go colorblind, green checks, red X's, lots of columns, rows. There'll be 2 columns, and one will say PD medical and one will say PD trauma. And this does not affect trauma. I'll explain why in a minute. But for PD medical, you know, so that's your 1-year-old RSV, your 2-year-old asthma, your 3-year-old pneumonia, you know, your 4-year-old abdominal pain, all of these that call 911. These are facilities that can still admit kids. So that's Children's Legacy, Texas Health Resources, Presby Plano, or PHOP, Centennial, Medical City, just not MCP or Baylor, because they don't admit kids. And, you know, again, we've been doing, with Baylor, they haven't admitted kids for years, and so I feel like I should apply the same policy to the place I work, since where their MCP is now not admitting kids. I think it's a bit of a commentary on Children's Legacy also becoming a bigger player up here. I think that they're getting busier, as we've talked about in previous CEs. They've added a pediatric intensive care unit. They don't do trauma right now. I've talked with DeMarco as recently as yesterday. They own all that open land around that hospital. I think eventually that campus will get bigger. I think the fact they have an ICU currently means that they're setting themselves up to do bigger and more complex surgeries. Their case volume will increase, and when their case volume increases, it will justify bringing more docs up here and developing the infrastructure for trauma as well. So eventually, I think this is going to be a big boon for us to have a pediatric trauma center up here and access to incredibly high-level pediatric care. And it will be interesting to see if the other major adult medical centers in town continue to do kids also. Because I think what you've seen in downtown Dallas and downtown Fort Worth is a migration to where most of the hospitals do adult stuff, and then all the kids stuff goes to one hospital. And I would say I predict in the next 5 to 10 years that evolvement up here too. I don't think this changes pediatric trauma, because pediatric trauma was never admitted to pediatricians at the hospital anyway. So the way it is always rolled at MCP, and my understanding of how it is rolled at Presby, is that the trauma surgeons will admit kids all the way down to about age 14. So 6 months ago, if you had an 8-year-old with a pneumothorax, we'd do what we needed to stabilize them, you know, put in a chest tube, etc. But that was always already going to be sent down to Children's, the Level 1 Trauma Center. So that this recent change, I don't think, is affecting the trauma perspective. If it's trauma and they're 14 and above, then that would potentially stay at MCP or at Presby, with this caveat. If it's neurotrauma, so they have a bleed or a skull fracture, and they're under 18, they're still going to get transferred downtown, because the only PD neurosurgeons are downtown. So that's a lot of stuff to try and memorize. Here's the way I would remember it. Okay, PD medical, these are the facilities. PD trauma, I look at my flight criteria. We have pretty liberal PD flight criteria. If it doesn't meet PD flight criteria for trauma, I'd go to MCP or Presby. We're going to stabilize, possibly admit there, may transfer if they're under 14 or if they have neurotrauma. Okay? I think this will get easier 5 years from now as Children's Legacy infrastructure continues to build out, but we're going to be in an in-between phase, certainly for a couple years.
Are you going to look at possibly making that flight criteria a little bit even more liberal for PDs now?
I don't think it didn't. I guess what I'm trying to say is it didn't change anything we were doing before. None of those kids that were 10 and had a ruptured spleen or at MCP or Presby, or an 8-year-old with a pneumothorax were staying anyway. Those have always been getting, now, if they need an operation, the trauma surgeon at either facility will operate if it's emergent. If they need a chest tube, we're going to put in a chest tube. But then eventually, if they're under 14, they're going to end up down there. I checked with Dr. Simonson of CareFlight and Methodist, and at Methodist, which is the other level 2, If the child is under 16, they get transferred. They stabilize them there, and then they transfer them over to children's. So this really isn't changing trauma flow compared to what we've been doing for the last year or two. It's changing the medical stuff. And that since MCP is not admitting it, I think we should take it to a facility that can. Pediatric endotracheal tubes, we're going to all cuff tubes, doesn't matter the size. The initial research when we were in school was that cuffed endotracheal tubes cause tracheal stenosis or scarring or sloughing or vocal cord injury in little ones. The recent research says not true. In fact, they're more easy to come out because they're not cuffed and they're not causing any of those injuries. So we're replacing ours, and all our tubes, no matter the size of the person, will be cuffed. CPR documentation. I've got a 5-minute tangent for this for y'all, and I want you to understand the why behind what we're going to do. So the issue, we're often missing the code summary, or at least part of the code summary, on a cardiac arrest. The code summary is the electronic information that comes off the LifePak 12 or the LifePak 15 that sort of describes what we did. What was the first rhythm? When did we what was the time we put the pads on? What was the time of the first defibrillation? How much joules did we use? What was the post-rhythm analysis? It measures the rhythm the whole way through. It only captures the code summary if you're in paddles mode, not lead 2. So that presents a potential issue there, and that's why the recent reprogram. I'll talk more about that. The other issue is that sometimes the code summary can be difficult to attach, right? So you got safety pad and the cable and the LifePak sometimes get moody, won't talk to each other, and you can't get the code summary to cross over. I'm optimistic that's going to improve. We have the new Armor hardware here. It's the updated hammerheads or safety pads. And I believe the last bit of troubleshooting we have is to get them to talk to the printers that are at the hospitals. Apparently they don't want to talk. And so we may have to get some new printers so they can print out. But then you will be working on a 2012 device rather than, think about the involvement in laptops in the last 6 years, and then extrapolate that to what we've been carrying versus a brand new one. And I think you'll see the connectivity should be a lot better. Why do we care about the code summary? For 2 reasons. First, one of my goals for 2012 is that we come meet with you in a shift or 2 after you run a shockable rhythm arrest. Because this is not punitive, this is to learn. And I think you get better if you sit down and it's just kind of like a PIA that you do after every fire. Well, the medical version of a fire is a VFib or VTAC, a shockable rhythm arrest. And so we want to go over it a little bit. See how we did? A lot of these are going to be attaboys. Hey, look how good you did. So what we intend to do is come meet with everybody that was on the call a shift or 2 after it happens. We need the code summary to be able to do that. We need the whole thing. So we'll print it out. It's got some software features to where we can say, hey man, you guys did awesome. Y'all were first responding engine. Y'all were on the chest 92% of the entire 30 minutes you were with the patient. Y'all did great. Look here, the first defibrillation, the pause was only 12 seconds between hands off chest, defibrillation, hands back on chest, or auto pulse restart. That's amazing. Now, hey, here on the third one, the third defib, there was about a 1-minute peri-shock pause between when you stopped, when you defibrillated, and when you restarted. And I'd say, do you guys remember why that was a bit longer? And you might say, well, we dropped the patient off the 3rd floor off the cot. They bounced once, hit the floor, and then we went down and scooped them back up and got them back on the cot, and then we started compressions again. So it took a little while. We're like, oh, okay, understandable. Now that would be, now we just have the conversation about, what was the pause? And you might say, my gosh, I didn't know we had that long of a pause. We gotta rehearse getting that auto pulse started faster. So anytime you look at yourself on a critical call, I think there's probably room to get better. But I want you to understand this is not a peer review kind of thing. This is a, hey, let's sit down at your station and get better. So we'll schedule it through operations. The other thing is to participate in the Resuscitations Outcome Consortium trials, we have to have the entire code summary. I can't have part of it. I got to have the whole thing. And I want to participate in those trials because I think they're going to make us better. So here's the hitch. Sometimes we start a code on your LifePak and we finish the code on your LifePak. And the current software can only accept one code summary, not both. And we got to have both so I can come talk to you about the code, or Meg, who's going to be tasked with this, is actually the one that's going to be coming out a lot and talking with you about the code. And so Southwestern can have all its information so we can participate. So there's two fixes. The easy one option would be, you can just, if you're on the med unit and y'all are on the engine or truck, he can drive in and run the whole thing off of y'all's life pack. One of y'all's probably going in with him anyway. And so the large apparatus, most of the time, is going to be following to pick up their person and could get it back. So that's one approach. But we have to have a backup approach in case you indeed leave and you've cabled over and we have two separate code summaries. So here's what we're going to do. Nothing would change for you if you're on the med unit. You would still attach your LifePack 15 code summary, write your run report, everything the same way you normally would. What would change for y'all if you went back to the station is you would open a run report on your safety pad. You only have to input a little bit of information. You'd have to input the patient's name, the incident number. You will have a disposition button of LifePack code. I believe it's LifePack. I think we're going to use the word LifePack code. It's going to be something like that, like LP code. That will get you out of all the lockouts. So you don't have to fill out a bunch of other information. And then you would attach the code summary. And that way, when it hits the server, there'd be two incident numbers. And each incident number, one would be the full report with the 15 code summary. One would be the dummy report, essentially, the sham report with just that little bit of information, but it's got the other LifePack code attached. We have same incident number. So name, incident number, disposition of LifePack code, and attach the code summary. All LifePacks have been reprogrammed to start up in paddles mode. Yes, that means we are making 0.5% of calls easier and 99.5% of calls one or two more clicks. But the fact is, the only way we can get this information every time is if you start up in paddles mode and stay in paddles mode. And what was happening is when we start in lead 2, we were running some codes in lead 2. And, or it would revert to lead 2 halfway through the code or something like that, and we'd lose all the information. So all LifePacks have been reprogrammed to start up in paddles mode. So if you run on a chest pain and they're not dead, they're alive, you're going to have to manually switch over to lead 2. But I believe that's just one punch or one or two clicks. Am I right? It's pretty straightforward. And then we have a built-in backup. So if it's 2 in the morning, if it's 10 p.m. or whatever, and you cannot get your code summary to attach, you're at the hospital, you've gone back to the station, you can't get it to attach, email EMS FD Supply. And on the next business day, somebody from the EMS division should come out to your station, to your LifePack, and download the information off the LifePack, because we have a finite amount of time to get the info off the LifePack. And then we will actually go in and administratively addend the code summary to the run report that way, if you can't do it in real time. And then the third layer of backup is going to be when Meg comes to work every day, she's got a BioView alert, which is the email that says you ran a cardiac arrest, just like I get. And she's going to log into the computer and look at your run report. And if it has the code summary attached, then she'll print it out, put it in the software, and schedule a follow-up. And if there is no code summary attached to it, she's going to email EMS FD Supply and come out and get it off of the LifePack. All right, and just a reminder before we break, this is why we do it. All right, this guy was dead, bystander CPR. There's our hero, and the guy's at Sixes, and he came to visit Sixes a couple days ago. He was a CPR from December. So, I don't have the final stats tallied yet, but I can tell you that from the dead to alive perspective, our overall survivorship and certainly our shockable rhythm survivorship for 2011 are looking really good. I'm believing we had an overall survivorship of at or above 10%, which is the best we've had in a couple years. And I think our shockable rhythm survivorship, so Utstein witness shockable rhythm, was up in the high 40s or maybe even 50%, which is just ridiculously good. I'm talking, we were doing great the last couple years, hitting like 35, 40%, and I'm thinking last year was even higher than that. We're still inputting some of the December CPRs, but preliminary compliments to you guys. I'll give you the hard numbers soon, and here's one guy who thanks you very much. Go get some lunch. All right, thanks guys.